Hello, everyone. Hello, colleagues. Good afternoon, good morning, depending on what side of the Atlantic you're joining us from. My name is Foyeke Adibagbo, and I work as a program manager with the USAID Nigeria Health Office. I'm very pleased to welcome us to today's webinar and kick it open. This webinar is co-convened by two of USAID's flagship social behavior change awards, Breakthrough Action and Breakthrough Research. And it's one in a series of webinars that focuses on disseminating findings from Breakthrough Research's, one of Breakthrough Research's research investment in Nigeria, which is the Behavioral Sentinel Survey. So today the session is focused on looking at findings related to malaria outcomes, as you can see on the opening slide. So we do have the very privilege and honor to have with us the Health Population and Nutrition Office Director for USAID Nigeria, Paul McDermott. He is also the lead on the PMI Nigeria program, and he would be delivering an opening remark to officially kick off the webinar and the discussions today. So without further ado, I would like to invite Paul to welcome us all to this webinar. Over.
Thank you very much, Foye. I don't know if a video is needed. My camera doesn't seem to be working, so I'll just go ahead and start. Good afternoon to all distinguished colleagues who've made this time to join this important technical discussion co-convened by Breakthrough Research and Breakthrough Action. We're all aware Nigeria contributes to 25% of the global malaria burden and accounts for 19% of the global estimated malaria deaths. I'm going to stop here and just ask if everybody can hear me. Foye, can you hear me?
Yes, I can hear you. Yes, Paul, I can hear you.
The 2018 Nigeria Demographic and Health Survey found the malaria prevalence to be 23%. The 2018 Nigeria Demographic and Health Survey found the malaria prevalence to be 23% and fever prevalence to be 24% in children during the 2 weeks before the survey. Of those with fever, 72% sought advice for treatment. This is a 6-point increase compared to 2015. So that effort should be maintained to reach 90 to 100%, which is the goal of the country program. In contrast, only 14% of children should be addressed to ensure providers follow best practices. As a response to strengthen overall behavior change to improve malaria outcomes, USAID Nigeria's efforts include intensification of fever, provider adherence to case management guidelines, and consistent bed net use, maintenance, and care. This webinar focuses on the results of the USAID-funded Behavioral Sentinel Survey on improving malaria outcomes through social behavior change, or SBC programming. It will provide data on how we can consolidate our gains and improve adoption of priority behaviors and uptake of services by key vulnerable groups. Breakthrough Action and Breakthrough Research are USAID's flagship social behavior change partners. While Breakthrough Action applies existing evidence, tools, and approaches to increase coverage of social behavior change interventions, Breakthrough Research advances and disseminates research around social behavior change technical areas and interventions, including malaria programs. They both share a result of increasing the practice of priority health behaviors and enabling social norms for improved health and development outcomes. Breakthrough Research addresses a clear need for increased study of SBC interventions. USAID investments in Nigeria examine mechanisms of effect in large multi-component interventions. It raises questions of cost-benefit or cost-effectiveness, as well as exploring challenges in implementation that may negatively affect behavioral impact. Breakthrough Research fosters the systemic exchange of evidence across health areas by producing, packaging, and disseminating research evidence to support tactical, real-time application of data by policymakers and SBC implementers in their work. Over the course of today's webinar, Breakthrough Research will lead us through a technical presentation that explores the relationship between several determinants or ideational variables that are key to malaria behavior outcomes. This is based on data collected from the first of 3 cycles of a behavioral sentinel survey carried out in Sokoto, Kebbi, and Zamfara, which are in the northwestern part of Nigeria. Our presenters will walk us through the details of the methodology for this innovative survey, which will collect data to help deduce the effectiveness of SBC program investments through breakthrough action over the life of the activity. Today's webinar is one of several activities and approaches through which breakthrough research assures social behavior change evidence is accessible to implementers, policymakers, and other development partners. This webinar is presented in a format that allows it to be easily used for policy and programmatic decision-making. For the National Malaria Program in Nigeria, this evidence could inform possible shifts in malaria SBC programming and strategic planning. I encourage you to participate today. Download the technical report and relevant malaria briefs that Breakthrough Research will share during the course of the event. Review and examine the results that we've achieved so far, and engage our presenters and Breakthrough Research colleagues after the webinar is over. Again, I thank you for making the time to be part of this technical exchange.
Thank you so much, Paul. Thank you very much. I think we're particularly honored to have you being able to join today's webinar and kick us off and open up the technical exchange like you rightly stated. So without further ado, I would introduce our presenters. But before then, just remember, if you haven't yet introduced yourself, feel free to use the chat box to drop your names, your organizations, your country. Also, during the course of the webinar, please use the chat box to drop your comments, your questions, your suggestions, so that you don't forget them. At some point after the presentation, we would have other colleagues facilitate the Q&A section so we can have some robust discussions around your thoughts and questions. So today we would be hearing from 3 panelists. Dele Abegunde, who's the Chief of Party for Breakthrough Research, will be taking us through certain aspects of the presentation. Temitope Ogunbi is our second panelist. He is with the Breakthrough Action and is the Senior Technical Advisor for Malaria. He would also be leading us through a couple of the slides. And finally, we do have Emily White Johansson, who is the Deputy Chief of Party for Breakthrough Research and will be leading us through a couple of the slides as well. Following that, we would have Sherry, and I think Udo facilitate the Q&A section, and we will be back. I will be back to close the webinar. So that's like the flow of things for today. I'm handing it over now to Dele to, hit us off.
Thank you very much, Foyike, and I want to appreciate Paul McDermott for that terrific opening remark that we got. I wish I would get a documentation of it so I can make reference to it. Thank you very much, Paul and Foyike. And today, just to give you an overview of what we'll be going through, I will be giving you a teeny-weeny bit of what we are, Breakthrough Research, and Breakthrough Action. Temitope will be talking to you about what they do and how we sync so well together. Emily, we then take on from there to explain what is the Behavioral Sentinel Surveillance Survey, what we call the BSS survey for short. And then the focus of today is on malaria. We'll be focusing on how formative research informed the BSS survey, the new ideational metrics related to malaria that is coming out from the BSS survey, the key BSS findings, and the SBC program implication will be explained to us by Temitope Ogunbi, and then I will then talk about the future work as we round up the presentation. Next slide, please. Like Paul let us know, Breakthrough Research is USAID's flagship project for social and behavioral change, SBC research and evaluation, even globally. In the Nigerian Breakthrough Research, globally, Breakthrough Research began around August 2017, and it's going to be wrapping up in July 2022. The Nigerian activity started in January 2019, and our office began in 2019 September, and we've hit the ground running since then. We are in close collaboration, as was said, with our sister project, Breakthrough Action, and other IP. Breakthrough Action does the implementation on the field, and we support Breakthrough Action's work with programmatic evidence manufacturing that informs their program and how they change their program as the work go on. Next slide, please. I will hand over to Mitokwe, who will be our colleague from Breakthrough Action, to tell us a little bit about Breakthrough Action.
Thank you very much, Dele. Yeah, so Breakthrough Action in Nigeria is also USAID's flagship project for social and behavior change. The overall goal of the Breakthrough Action Nigeria project is to increase the practice of 17 priority health behaviors in the areas of maternal, newborn, and child health plus nutrition, family planning, as well as malaria. Intermediate results of the Breakthrough Action Nigeria project include improved individual and social determinants of health, strengthened SBC coordination and collaboration among US government partners, as well as strengthened SBC capacity of both the national and subnational public sector entities. Next slide, please. So the Breakthrough Action Nigeria project, we currently have a total of about 12 priority behaviors for the integrated SBC program. These priority behaviors are spread across different milestones, which we see on this slide. For instance, we have from pre-pregnancy through pregnancy, childbirth, the first 6 months of a child's life, from 6 to 24 months, and finally from 2 to 5 years. So for instance, during pre-pregnancy, the priority behavior in focus is to have a couple use the modern contraceptive methods, including the long-acting reversible methods, to avoid pregnancy for at least 24 months after a live birth. During pregnancy, the focus is to get pregnant women to attend ANC on time, and also to complete a full course of ANC visits. Also, we expect that pregnant women will take intermittent preventive treatment of malaria in pregnancy, taking sulfadazine pyrimethamine during the ANC visits. And this continues across all the way to when the child is 2 to 5 years. Next slide, please. Our other priority priority behaviors, especially for malaria, include increased insecticide-treated net use, increased uptake of intermittent preventive treatment of malaria in pregnancy, increased prompt care seeking for fever, increased demand for testing before treatment, increased adherence to completing artemisinin-based combination therapy for malaria, and on the provider side, to increase providers' adherence to the National Malaria Case Management, which of course is malaria diagnosis and treatment, and as in addition to adhering to the National Malaria in Pregnancy Guidelines. Next slide. For our integrated SBC program, we use a coordinated multi-channel approach in our integrated program. Our strategy is the umbrella type strategy, which has an overarching brand which encompasses all the included health topics. Some of the approaches we deploy include community mobilization. Under community mobilization, we focus on community social behavior change. This includes using or leveraging on community structures such as community volunteers, ward development committee members, to reach the target audience. We also have the community capacity sustainability, which empowers communities to take ownership of the program. Other approaches include mass media, where we use radio, print, TV, social media to reach our target audience. The mobile and digital approaches use SMS and the interactive voice response technology to reach the target audience. Our advocacy targets religious leaders, traditional or opinion leaders, while the provider behavior change initiative seeks to positively influence provider behavior by addressing the drivers of behavioral problems and providing solutions for improvements in service quality. Next slide, please. So, Breakthrough Action in Nigeria implements the SBC programs in 11 states and the FCT. From the map, the blue states represent states where we have integrated MNCH plus nutrition, family planning, and malaria. In the FCT, we have integrated MNCH plus nutrition and family planning, while the orange colored states represent states where we have malaria implemented. This includes Zamfara, Oyo, Plateau, Nasarawa, Benue, Cross River, and Akwa Ibom state. While the green state is Kano, where we implement, TB SBC programs. So Breakthrough Action Research is implemented this BSS study in Kebbi, Sokoto, which are the integrated states in the northwestern parts, as well as in Zamfara, which is also in the northwestern parts of the country. All right, so I will hand this back to Dele, while I'll come back to talk about the implications the findings will have for SBC programs. Thank you. Over to you, Dele.
No, actually, I'll take it. So this is, thanks a lot, Dele and Temitope. It's Emily White Johansson, who's the Deputy Project Director, Director of Research and Evaluation at Breakthrough Research in Nigeria. So I'm going to talk through the next slides about the Behavioral Sentinel Surveillance Survey, or the BSS as we call it, as well as some of our specific malaria research results. So the main objective of the BSS is to assess the effectiveness of integrated versus malaria-only SBC programming on malaria, family planning, and maternal, newborn, and child health plus nutrition outcomes among pregnant women and women with a child under 2 years who are living in the BA program areas within those 3 states in the Northwest. The BSS measures priority behavioral outcomes across each of these health areas. Those are standardized with the measurement done in the DHS survey. But importantly, we also measure psychosocial influences, or ideations, across cognitive, emotional, and social domains. And those are theorized as intermediate determinants of behavioral actions and decision-making. So the psychosocial factors across each of these health areas were developed based on the Kincaid theory of strategic communication and behavior change. This theory posits a pathway from exposure to communication activities, so all of those activities that Temitope just discussed and that BA runs, from mass media, advocacy, community engagement strategies. And the pathway is theorized to go through 3 ideational domains and 9 ideational subdomains that then could lead to changes in both intentions to conduct the behavior and the behavioral action itself. So survey questions are intended to measure as many of these domains as possible across all of these priority health behaviors. So if you figure that we have 17 core behaviors, 9 subdomains, that's a minimum of at least 150 ideational questions to get a comprehensive look at the drivers of all of those behaviors. In reality, we had many more questions than that, But still, it wasn't as comprehensive as we would have liked, but we did have a trade-off between being comprehensive and risking respondent fatigue that could jeopardize overall survey quality. So the main study population for the BSS, again, was currently pregnant women and women with a child under the age of 2 years. Again, these populations correspond to the main life stages focused on by BA and which Temitope had described earlier. Specifically, they focused on the priority, what we call 1,000-day window of opportunity that extends from pregnancy through the first 2 years of life of the newborn. And again, we collected data in all 3 states, but that data are only representative of the BA program areas within the states and not the states themselves. The study to design involves both cross-sectional and cohort components to provide estimates of prevalence of behaviors and ideations over time. We use repeat cross-sections of women with a recent completed pregnancy at 3 points in time during the BA program cycle. That's baseline, midline, and endline periods. And the results I'll present today is from our recent baseline survey. We will also follow a cohort of women who were pregnant at the time of the baseline survey to document their 1,000-day window of experience. So this is also a quasi-experimental design, such that in the sense that we're comparing geographies with integrated programming, Kebbi and Sokoto states, with those with vertical malaria-only programming in Zamfara state. The sample size includes just over 3,000 women who were pregnant at the time of the baseline survey, and another 3,000 women with a recent pregnancy based on a random sampling. And in today's presentation, I'll present both the bivariate and multivariate analyses. And so for multivariate analyses, we present the predicted probabilities of an outcome occurring, and those are derived using mixed effects logistic regression models that are adjusted for ideational and socio-demographic variables such as household wealth, maternal age, maternal and spousal education, as well as maternal and spousal employment. And I just also want to encourage you, the final baseline technical report is publicly available and it's on our website at the link here. It includes a full description of the survey methods and a complete descriptive results. I really do encourage everyone to download the report if you're interested, to get a sense of the breadth and richness of the data we've collected, not only for malaria, but also for family planning and maternal child health. And briefly, I just want to, before we get into the results, make sure everyone's familiar with the pillars of the malaria control strategy in Nigeria and elsewhere. First, malaria prevention interventions, notably distribution and use of long-lasting insecticidal nets, or LLINs. The aim is to have all households have at least 1 LLIN for every 2 household members, or what's referred to as sufficient LLIN access within a household. And while the aim is also to have all people within the household sleeping under an LLIN each night of the year to prevent malaria, there are priority populations, and that includes pregnant women and young children. For malaria and pregnancy, again, pregnant women, as I mentioned, are encouraged to sleep under LLINs in order to prevent malaria. But in addition, an additional intervention during pregnancy is to receive intermittent preventive treatment during their antenatal care visits, or IPT. And IPT is defined as 3 or more doses of SP Fansidar, an antimalarial drug, to be received during antenatal care visits for all pregnancies, even healthy pregnancies. And malaria case management includes seeking care from more formal medical sources, getting tested for malaria, and receiving treatment based on the test results. There's also seasonal malaria chemotherapy, SMC. I won't discuss that today because it wasn't measured in the baseline survey. But just to also note that we do plan to expand our malaria data collection in the midline round, and that could potentially include ideations or behaviors related to SMC. So in terms of the formative research that informs the BSS, Breakthrough Action, our sister project, had conducted wide-ranging formative work during its first year on the ground that we drew on in developing the survey questionnaire. Some of their results were from literature reviews of previous research or their own formative qualitative interviews, and those indicated reasons for uptake of certain malaria prevention and treatment behaviors. So for example, Low IPT use in qualitative research has been associated with poor awareness of malaria risks in pregnancy, low ANC attendance, and IPT not being offered by the provider. For case management, some of the factors associated with not seeking care or poor treatment practices included healthcare costs, facility distance, negative views of health services, and gender dynamics or sociocultural norms. So all of this previous research and the formative work that BA did really helped us to shape the questions that were asked in our baseline survey. And just also to take a moment to talk a little bit about the ideational metrics. So there's a lot of ideational metrics in the literature related to knowledge, attitudes, intentions in health areas such as for family planning and malaria. And I'm sure some of you on this call have participated in that malaria ideational research. There's a lot less published in other health areas of maternal child health, such as for diarrhea, pneumonia, or pregnancy and childbirth. And just to say, it's really important to have this kind of information because in the theory of strategic communication and behavior change, ideational factors are so important and are really the basis for SBC programs. So that's what they target in order to spur behavioral change. It's the basis for investments in SBC and in BA, both in Nigeria and globally. So it's important to test the underlying relationships between these ideational factors and the behaviors according to this theory of change. So for malaria, I will say we adapted, or actually we really used questions from previous malaria ideational research that was conducted in Nigeria by Johns Hopkins University and Stella Babalola, who was also an advisor on the survey questionnaire. For IPT analysis, there was some malaria ideational research related to malaria and pregnancy that we drew on, but we also expanded because of the unique nature of the BSS going across other health areas to also include pregnancy-related ideations. And I think that's a real testament to the uniqueness of the BSS that we could do that. And so those pregnancy-related ideations were developed, are new in this BSS. And the questionnaire was developed jointly with BA and with input from outside malaria and child health experts. And again, as I mentioned before, we asked a limited set of ideational questions across each health area, or we would have just had a very long questionnaire. So we prioritize the questions based on their importance programmatically. So in terms of the malaria case management ideational metrics, again, we adapted this, or we used this from previous ideational research in Nigeria and elsewhere. But for each health area, we tried to have at least one question for each specific ideational domain. For example, for knowledge, we asked sort of the standard question at this point, what do you think causes malaria? And then we coded the data as those who provided correct answers versus those who did not. For beliefs, we had questions such as, even if the malaria test is negative, I always worry it may still be malaria. Or a health provider is the best person to talk to when a child is sick. And these Likert scale statements were coded, their responses were coded as strongly agree, somewhat disagree, strongly disagree, or don't know. We also included questions related to emotional and social domains, including self-efficacy and social influences on decision-making. We use the same structure to develop ideational metrics across all of the health areas that we mentioned, and this is also for IPT that included both malaria-specific ideations and pregnancy-related ideations. And again, that is new from the BSS and provides a unique building on what's been done before to have this broader perspective into the analysis. So for example, for knowledge, we asked what can happen to a pregnant woman's unborn baby if the woman gets malaria? Or in your opinion, if a pregnant woman goes to ANC, what are the benefits to herself? For beliefs, we had statements such as pregnant women need antenatal care only if they are sick, or the medicine given to pregnant women to prevent malaria works well to keep the mother and baby well. And again, we coded these Likert scale statements as strongly agree, somewhat disagree, strongly disagree, or don't know. And of course, we also include the emotional and social domains, including, again, self-efficacy and social influence on decision-making. So now we get to the key findings. So I'll present these findings according to SBC program priorities that we've identified. First, behavioral patterns. So at this baseline period, how frequently do respondents practice the promoted health behavior? What are the key behavioral patterns by geography or socio-demographic characteristics? Knowledge and beliefs. Are respondents aware of promoted health behaviors? Are certain beliefs held by respondents that could impede progress? Barriers. How do respondents view health services in their communities? What are the main reasons for choosing certain treatment locations or for not using services at all? Social influence and decision-making. How do health decisions get made in households and who mainly influences these decisions? And then at the end of the presentation, we'll take this all together. So all the ideations across knowledge, beliefs, social influences, etc. And we, in our regression model, we look to see how important are the individual components of behavioral change frameworks. What ideation should SBC programs target to maximize impact? So in terms of behavioral patterns, on this slide, you'll see that across the study area on the left side map, there's a high proportion of households with at least one LLIN available. However, LLIN access within the household, as shown on the right side, is much lower, with much fewer houses having at least one LLIN for every 2 household members. And this is particularly apparent in Southwest Kebbi, but also across Sokoto and Zamfara too. So that was LLIN access, but what was found in the BSS results for LLIN use, and this mirrors results that we've seen from the Nigeria DHS 2018, and that is that when there is sufficient LLIN access within a household, then there is high usage of the nets by pregnant women and young children. And so a continuing priority then for programs is to increase distribution in order to improve access. And in addition, we also see equitable usage across wealth and maternal education that's been shown in Nigeria and the DHS and in other settings due largely to LLIN distribution campaigns targeting these poorest areas. At this baseline period, and similar to the DHS, we also found low IPT use to prevent malaria during pregnancy, but also we show that it's quite inequitable coverage even within these very poor states in the Northwest area. And again, similarly, for pediatric fevers, there was also low and inequitable malaria testing among children under 2 years with fever symptoms. Now, in terms of knowledge, we found very high general knowledge about malaria, but as an important comparison, there was quite low awareness about pneumonia and diarrhea, which are the other main causes of child mortality in Nigeria and globally. So while nearly all respondents knew mosquito bites cause malaria and that sleeping under nets helps to prevent malaria, about half had never heard of or didn't know how zinc helps for diarrhea. Only 31% knew antibiotics were an effective treatment for pneumonia, and only 28% were aware that rapid or difficult breathing is a sign of pneumonia. There were also strong doubts about malaria testing across the study area. When respondents were given the following statement, even if a blood test is negative, I always worry it may still be malaria, 61% agreed with the statement, and in fact, 1/3 strongly agreed with the statement, indicating a firmly held misperception about malaria test accuracy for negative results. And this is in line with qualitative research from this region and also elsewhere in sub-Saharan Africa. For IPT uptake, we asked women who did not take any medicines to prevent malaria during her last pregnancy why she did not do so. And the most commonly cited reason was respondent and spousal opposition. And the theme of spousal opposition is common actually across most health areas, as we've seen in other webinars. We did not ask follow-up questions to understand the nature or reasons for this opposition, but that is an important avenue for further research in order to inform SBC programs and messaging for this key group. Other commonly cited reasons included it was not available, not offered, she did not attend ANC, it cost too much, and she was healthy or not feeling sick. So in my view, these responses suggest two things. First, that IPT is highly integrated with ANC, as we know, and that we need to also look at broader pregnancy-related ideations. And then secondly, that there are still misperceptions about taking IPT to prevent malaria, because even during healthy pregnancies, that it's not just for sickness. Among women who sought care for their child under 2 years with a fever in the past 2 weeks, we asked them about reasons for choosing the treatment location visited. As you'll see, provider trust, nearby location, and perceived effectiveness of treatments were the most common reasons cited for choosing the treatment location. Among women who attended pharmacies, short wait time, nearby location, and low cost were more commonly cited when compared to women who attended government hospitals or PHCs. And among women who attended government hospitals or PHCs, that's primary healthcare centers, provider trust, effective treatment, and respectful care were more commonly cited when compared to women who attended pharmacies. In terms of spousal influence on sick child care decisions, when we asked women who besides yourself may influence your decision to seek care for a sick child, the vast majority of women reported their spouse or husband. Yet, as you'll see in the next series of slides, spousal influence was not significantly associated with any of the malaria case management outcomes, care seeking or diagnosis or treatment practices. And that's in contrast to other health areas where we examined this, such as maternal health services, where spousal influence was associated with the outcome. So now we get to the ideational relationships, where we bring this all together in regression models to look at which variables are independently associated with the outcome. So the first slide shows the results of the multivariate analysis where IPT use was the outcome. And we see that ANC knowledge and beliefs are important for IPT uptake, independent of other ideations and sociodemographic factors. Respondents who knew that women should have at least 4 checkups during pregnancy, who were aware that women should go to her first ANC visit in the first trimester or when she thinks she's pregnant, who knew that IPT is a benefit of ANC attendance, or who knew that prematurity was a risk of malaria during pregnancy. All of these responses separately were all about 1.2 times more likely to receive IPT during that last pregnancy for those respondents compared to women who did not have this awareness. Respondents who believed that pregnant women only need ANC when sick were 23% less likely to receive IPT during her last pregnancy than those without that belief. Respondents who believe pregnant women attending ANC 4 or more times have safer pregnancies were 1.3 times more likely to receive IPT than those also without that belief. So as you'll see from these results, ANC knowledge and beliefs, in addition to knowing about the risks of malaria and pregnancy, is important and significantly associated with IPT uptake, since IPT obviously is an essential component and one of many components provided as part of quality ANC care. In terms of case management, we also see that malaria beliefs and positive perceptions of health services matter for taking a child with a fever to a formal medical source and for having that child tested for malaria, independent of other factors. And just to say, formal medical source in our analysis is defined in a standardized way with a DHS definition to include government hospitals, PHC, dispensary health post, community health outreach post, nursing, maternity home, or private hospital clinic. So women who believe facilities often have medicines for sick children were 1.9 times and 1.6 times as likely to seek formal care and get a child tested for malaria. Women who believe the blood test is the only way to know a child has malaria were more than 2 times as likely to have the child tested for malaria. And women who felt confident that they could convince their husband to seek care for their sick child were more than 2 times as likely to get a febrile child tested for malaria. But just a word of caution in interpreting these results is that there may be some reverse causation, such that women, since we're only showing association, so women who had a child tested for malaria must have visited a facility with tests in stock, and so she will likely answer positively about our healthcare experiences, and that facilities do have items in stock. So that experience then shapes her perception, and in turn, that also may influence her future care-seeking behaviors. There was also a lot of interest in our questions related to confidence in the malaria, the ideational questions related to confidence in malaria tests and perceptions of the negative test results. So we ran our multivariate regression analysis with those separately as outcomes. So first, confidence in the test results, or agreeing with the statement that she believes a blood test is the only way to know if a person has malaria. And also trust in the negative result, or agree with the statement that even if the test result is negative, I always worry it may still be malaria. So what we found is women who believed fevers were almost always due to malaria were more likely to distrust the negative result or worry that it could still be malaria even if the result is negative. Women who said the health provider influenced their decision to seek care for a sick child were less likely or more likely to trust the negative results. And women who believed the health provider is the best person to talk to for a sick child were more likely to feel confident in blood tests and less likely to trust, and more likely to trust the negative result. So this suggests, or could potentially suggest, that respondents who believe most fevers are due to malaria may be less likely to trust the negative result. And inaccurately believe most fevers are due to malaria, even in high burden settings. And these results may also indicate that positive views of health services could translate into positive views of diagnostic tools, or having confidence in blood tests and trust in negative results. So those are just some suggestions from these results. So now I'll turn the presentation back to Temitope, who will discuss the program implications of these findings and how BA will use these results for program learning and adaptation. Thank you.
Thank you, Emily. Yeah, so what implications do the BSS findings have for SBC programs, including our own program? The BSS findings, did show that there's a high LLine use if households have sufficient nets. And of course, by sufficient nets, we are referring to one LLine for every 2 persons in the household. So most households definitely, don't have enough nets. Therefore, improved access to nets should be the top priority for programs. I mean, if access is increased, there'll definitely be a corresponding increase in the use, as has been shown from the findings. The brief for the findings actually showed that there was low use despite having sufficient nets among older women aged 35 to 49 years, those living in large homes or those living in Sokoto. Despite the fact that there was sufficient nets among this category of people, there was still low use of the nets. So, I mean, SBC programs will need to target this particular category of audience with messaging to increase net use. Also, probably there will be a need for further research to uncover the reasons why this category of people still do not use the nets, even when the nets are in sufficient quantities. IPTP use is linked to pregnancy ideations, as Emily has pointed out, and it's definitely less about the malaria beliefs, as has been pointed out in the findings. So for this, SBC messaging definitely could focus on improving ANC knowledge and beliefs, emphasizing IPTP as an ANC benefit and raising awareness about the risks of malaria in pregnancy. So programs could target both the providers, the ANC providers, building their capacity around emphasizing these messages during ANC visits. Perceived and actual health services quality definitely also matters for IPTP uptake, requiring SBC programs to work closely with efforts to improve maternal health services. Some of these efforts definitely would include provider behavior change activities, which will focus on respectful maternity care, and of course, getting providers to adhere to the national guidelines and treatment policies. Next slide, please. So health services perceptions matter for care health seeking, malaria test update and results in negative test results, and trust in negative test results. This definitely reinforces the importance of perceived and actual health services quality to raise not only the service use, but also trust in diagnostic tools used by the health providers. We also do identify the fact that the lack of trust or the distrust in the diagnostic tools, especially the results when they turn out negative, is both on the provider side and on the caregiver or the client side. So definitely programs need to focus on how to increase the trust in these diagnostic tools on both sides of the divide. Provider trust, nearby location, and effective treatment, of course, were main reasons for choosing treatment locations. Healthcare costs were main reasons also for not seeking care or for choosing pharmacies, suggesting focus areas for improving health services. Our experience in the field shows that, some community members avoid some of the health centers because of the associated costs with malaria services in these centers. And so it will be important for programs to, advocate to policymakers and those that are in authority of these facilities to, look around the issues associated with the cost of malaria services. Programs need to focus on promoting self-efficacy and dispel misperceptions about fever causes, as strong doubts about the negative malaria test results persist, as found in qualitative research. So, both on the client side and on the provider side, there's a need for programs to improve provider trust and clients' trust in RDT results, especially when they turn out to be negative. SBC messaging could dispel myth that most fevers are due to malaria and support women's confidence to seek childcare to improve test use and trust in results. Again, we'd like to admit that this is also an issue that is on both the provider side and on the client side. Our program currently, promotes and helps providers to identify the fact that there are other leading causes of fever, apart from malaria. And since the burden and the prevalence of malaria has dropped over the years, providers still overestimate, the fact that most fevers are due to malaria. Provider behavior change interventions definitely can target health workers to improve their perceptions about fever causes, and provider behavior adherence to malaria testing and treatment guidelines can be improved through programs and activities that target the healthcare workers. Next slide, please. Self-efficacy in spousal communication is critical for seeking formal care, testing for pediatric fevers, and IPT uptake. Women's confidence in convincing her husband to seek care for children is important. So programs may need to think about ways to support women's empowerment to decide on how to care for sick children. Understanding the factors responsible for opposition to IPTP is definitely critical to IPTP uptake. The surveys definitely showed that spousal and respondent opposition to IPTP were commonly reported as barriers to uptake. More research will be needed to better understand the nature of this opposition to inform SBC programs. So I'll hand this over to Dele to take us through the next steps.
Thank you very much, Tope and Emily, for those illuminating presentations. I haven't done this. What are the next steps after we have analyzed and brought out this evidence from the data? Our next step is to conduct further BSS analysis to inform program adaptation and scale up in Nigeria. Even as we have done this, we continue to dig into the data to address specific issues and also to bring out evidence that we support program adaptation and scale up. Presently, we are preparing manuscripts in all of the health domains that we are focusing on for publications, so that all the evidence and the data, as much as possible, will be in peer-reviewed journals for eternal references. Also, like we were told at the beginning, the BSS study is actually a three-wave study. This is the baseline. We are already preparing for the midline survey, the midline survey. We would have done it, but for reason of COVID restriction, but we're looking forward to getting onto the field to conduct this survey early next year. The beauty of it is that it gives us opportunity for cross-sectional panels that even provides more opportunities for more rigorous analysis and bringing out the evidence in a very solid way. We have been doing it, and we are looking to be presenting the BSS results by specific health areas. We have started this webinar series since June, started globally, and then we came nationally. In the national webinars, this is the 7th of the wave of webinars in the national webinar series. So this will be an opportunity for IPs who are present and are seeing these results to engage with us. If they find areas that they want to explore, we'll be very happy to discuss with such implementing partner to collaborate with, even digging deeper into the data. Next slide, please. As I said, this is the 7th of the national wave of webinars, the malaria wave, which is today. In 2 weeks' time, we hope you will join us 30th of September for the family planning webinar. Again, this promises to bring out very interesting results that will inform family planning vis-a-vis SBC, not only in those 3 states that we have done the study, but might bring evidence that will also inform, even in that, inform policy making and program implementation in that region that the states we selected are. We will have our last wave of national webinar will be on the 7th of October, where we will be discussing a cross-cutting theme, inequalities in some of these ideational and behavioral factors in the population and how they link together. Also, this promises to be an interesting one, and it will be on the 7th of October. Next slide, please. The future work and the significance of them, I would like to also elucidate that these baseline results are a first step for assessing the effectiveness and cost benefit of integrated versus malaria-only SBC programs. That was the original focus of the study, but it's been expanded because of the beauty in the results that are coming out. We will highlight ideations and behaviors during this baseline period to inform SBC program scale up and adaptation, like we said, and they will be presenting new ideational metrics across maternal, newborn, and childhood diseases, childhood health, and then including nutrition areas, and quantify their relationship with behavioral outcomes to test behavioral change, the behavioral change theories, which underlies the programming that BA is implementing on the field. And it will be interesting to see this relationship between modulation of ideation and how behavior changes to increase demand generation issues. We link BSS results with routine. We like to link BSS results with routine program data or health facility records in the areas in which we have done the study to examine the impact of modulating behavior in the supply side, which is the population, and the demand side factors, which is the how utilization may have increased in the facility in future. We're looking forward to data on the demand, on the supply side, that will help us link the data, BSS data that we have on the demand side for this kind of analysis. So if any IP has this kind of data, we'll be pleased to discuss with such IP. Next slide, please. And that's about the end. I'd like to introduce those people who are behind the scene, leading this work and doing and motivating the beautiful results that are coming out from it. I'd like to introduce, appreciate Paul Hutchinson. He had introduced himself earlier, I think, in one of the question and answer thing on the chat box. He's a professor in Tulane University. He's one of our principal investigators, and is also leading the technical part of the analysis and all. Again, Paul Hewitt of the Population Council is also co-principal investigator, is the technical director on breakthrough research in Population Council, Washington. And Emily White, whom you have listened to, presenting and illuminating the results in a very brilliant way, is also the deputy director, deputy chief of party in breakthrough research in Nigeria, and the director, the technical director in Nigeria. Elizabeth Omoluabi and Akoni Akiyemi are from CRED. CRED was the organization that led the data collection in the field using highfalutin technological tools that brought a lot of validity on the data. We have also Dominic Mikas from Tulane. He's in the engine room with Emily and Udo and others, crunching the data and making meaning out of this sea of data that has been collected. Udo Chizom is our research coordinator in Breakthrough Research Nigeria, and then Stella Babalola from Johns Hopkins University, and then yours sincerely, the last of the pack, Dele Abegude, the Chief of Party of Breakthrough Research Nigeria. We'd like to also acknowledge Antwidi of the project director in Breakthrough Action. We've always been collaborating and communicating with him. He also was powerfully behind the design of the studies and also leading the interpretation of the results from Breakthrough Action's point of view. And of course, Matthew Oko in also Breakthrough Action. Having said this, I want to appreciate every one of you for coming and having this patience to listen to us. Next 2 weeks' time, we would like to see every one of you again. I encourage you to just spend some time to interrogate these results, ask questions, give your own view as I hand you over to Foyeke Adebabu. So at the round up and then conduct the question and answer section with Paul Hewitt and Sherry Ochisi.
So thank you very much, Dele and Tope and Emily and our presenters. I feel like we're out of time. I see that a number of questions that were in the chat room were responded to by either Paul or myself. I worry that we may not have the time to do some detailed review of questions. There are, I think, links have been put in the chat box to the technical reports. People are also asking questions about whether they will get invited to other webinars. I feel like the fact that your email has been registered in the listserv might almost guarantee that you'll be invited to the next set of webinars. People are also asking questions about where they could get other materials and links to the earlier webinars. So maybe Sherry, as you send the links to this one to everyone after the webinar, you probably want to include a link that helps people get at the previous webinars and they can listen to it at their own pace as well. So thank you so very much, everyone. It's been, I see a lot of thumbs up and thanks for the presentation. So I believe it's been a very enriching discussion or 1 hour and that you have gained something from this. The team is available to continue to engage, like Dele did say, so please feel free to reach out. Thank you so much, Paul McDermott. Thank you very much for staying up until the end. It was really a privilege to have you here. Thanks, Jose. Thanks, Uwem, and other colleagues that were able to join. So we will see you, hopefully, at the next webinar. Looking forward to seeing everyone at the next webinar on September 30th, I think, on family planning. Over. Thank you very much.